All right, so my name's Dennis Boyle. I'm a rheumatologist. My area of interest and expertise is that of communication, and we're going to talk about empathy. Unfortunately, we have a couple great videos, but those are um, not going to be able to be played. But what we're going to do is just give you we'll send out the one video, the Brene Brown video, and we'll go from there. So the first question is what is empathy? And does anybody in the audience want to unmute and tell me what they think empathy might be? Sally, do you want to take a shot?
I'm sorry, I didn't hear the question.
What's empathy?
Putting yourself in someone else's position, trying to understand their point of view.
Excellent. Perfect. Mazel tov, as they say. So it's really about putting the perspective of another, put your perspective in that of another, and it's walking a mile in someone's shoes. So, um, and so why do we think this is important? And we're sort of in a I like to try to be as interactive as possible, but this is more of the webinar kind of thing, so we're do the best we can. So why do we think it's important? So think in your mind about what that might be, and we'll run through a couple of the answers. What's the biggest reason? Anybody in the big room want to unmute and just say what they think? I guess we'll go ahead and just keep going. Sorry about that. So the first part is patient satisfaction. And I work at Denver Health, it was mentioned. The patient satisfaction is the big thing. We get the green box on our survey. And the most important question that they asked about this is, did my doctor listen to me or did my provider listen to me? So the biggest thing, and if you can answer the question properly and say, my doc's empathic or my nurse practitioner is empathic, um, they're likely to say he really or she really listened to me. It improves adherence. And so there's a famous Kaiser study. What do you, just in your brain, um, what percent of people actually take the medicines that we give them? Anybody? Numbers probably about 50%. There's a famous Kaiser study where um, they um, they actually got rid of all barriers. You're on the third floor. You get your lisinopril. You get the order for the lisinopril electronically. You go to the first floor. They say, "Are you Dennis? Here's your lisinopril, no copay," and you're out the door. And in that study, 60% of people pick their pills up. So the more you believe in what your provider says, the more likely you are to do what they say. So you get better outcomes, you get better adherence. Um, and of course, that's not Percocet data. If it's a if it's an oxycodone, the fill rate's a little bit higher than 60%, but that's another story. Reduces litigation, hence Copic talking about it. It improves the outcome with the patient, and I think that's because they're believing in, part of what we do, part of our healing is related to this. And I think in the time of burnout, um, the survey at the university hospital where I work at, the last survey had the inpatient nurse practitioners burnout rate is 79%. So the question at this point in time is who's not burned out more than who is burned out. And it really does help when you have that connection during the day, when you make that empathic moment. So how do you think we're doing? What do you think, Sally? You think we're doing great with this empathy stuff?
Sure.
Not so good. 70% of us in a surgical journal miss the opportunity to be empathic. So someone is saying, my daughter has appendicitis, I'm scared to death. And, we launch into, well, we're going to get this better and its success rate's great. And it's a chance for an empathic moment. Med students have some empathy and then we burn it out of them or break it out of them over the course of the 4 years. And certainly an internship really takes the empathy out of you. And we do know that training sort of helps. So there's wonderful article and book by Brene Brown. So Brene has written a lot about this, and hopefully Josh can show the Brene Brown video at the very end of this. But I think let's try to get through the PowerPoint first. Brene is a social worker who writes extensively on this. and has talked extensively on it. In fact, there's a wonderful book she has, Atlas of the Heart, and she actually has it's an HBO Max special on. She has like a 5-part series on this whole issue, so well worth watching if you. And it works, for affairs of the heart too. So you and your significant other can watch it. It's a pretty powerful stuff. She's great, and learn a lot from her. So where does it all occur? So this is interesting data. So this is a functional MRI, and functional MRIs are interesting. They're not the be all and end all, and there's some issues around it. But in a functional MRI, if you show something that creates empathy, this is what lights up. And the purple or magenta area on my screen, sort of that right supramarginal gyrus, is the main area. But you also notice that other areas light up. So there's 2 points of this. One of them is that it's in a number of areas. It's like a city. Where does commerce occur? It occurs everywhere. So empathy does occur throughout the brain, although there is one area, that magenta in the supramarginal area, where there's something called mirror neurons. And these neurons literally look differently than other neurons. And they do know that people that have a diagnosis of something like autism will have a decrease of the mirror neurons when you look at it. So that's the area that's where this all really occurs. So the next question is, do you think this can be learned, or do you think people are just empathic or not? I want to hear from the audience. Is there a way to let the audience talk to me, Sally? Anybody in the audience?
It can be learned, they're saying.
Yeah, it can be. I agree. So now there are people that are just incredible with this, and they're incredible naturally. And I have one person in mind. One of my old mentors was the most naturally empathic person in the world. So some people just come by it naturally. They learned it when they were 3 or something like that. But there's no question it can be learned. And I ran the communication program at the University of Colorado, and we literally had a person who had a disease that kept them from being empathic, and I worked with them extensively, and he improved. He got better at it. So it is something that can be learned, and but it is also something that we start early at. So this is about, I think, a 2-month-old. I have a grandson right now, so I'm good at this guessing the age thing. And what's interesting is when my little grandson starts looking around, he can see things. He's probably beginning to focus right now. He's at 3 months, so a little bit older than this, and it's just about the length of the distance of the crux of your arm where babies sit. So even at this young age, they start seeing, they start looking around, and even at the early age of 1 or 2, they have some empathy. So there's a study you can do with a mom. Moms, of course, often are the ones that are the most connected to the babies. And when a baby is a year old, can take a plastic hammer and can whack their finger and then go, ooh, and the baby will go, ooh. So literally, before the baby has learned the words mama and grandpa, which we're working on grandpa being the first word my guy learns. But literally, even before they're using words, they see mom hurting their finger, and they give signs that there's some empathy going on. So it's something that starts early. Indeed, it is innate. Some people are very, very good at it. And then, as the answer from the audience was, yes, it can be learned. So it is a bit nature. It is a bit nurture. It is a bit of, like many of our many things, many traits, and many diseases. There's both environmental and enhanced. So, and it's innate, and it can be enhanced or diminished. So, and here's 2 little guys, right? 1, 2, looking pretty empathic, looking like they're connecting with each other. So we'll see. So in your mind, what's the biggest hurdle for you guys being empathic with someone, or empathetic, whichever way you want to say it? Anybody want to yell out an answer? Time. I think I heard time, although it was a distant in the past. So yes, I think time would be the biggest one. So you got to see 22 people a day. You've got 15 minutes with this patient. They come in and they want to talk about their, oh my God. So this is what you run into all the, so we are on a time constraint, and that doesn't include then the 2 hours you have to go home to finish your charts and then create the charts for the next day. So time is a constant, and it's gotten worse, and it's a big struggle. Angry patients, and to say the least, this is a huge issue that has become much more of an issue, um, as our society itself has become very angry. So, societally, there's just media stations that are just angry. There's politicians that are angry at each other. The new normal is now this, and then of course, I think it was in Oklahoma, was it Tulsa, where there's a shooting of a physician around a pain med. So, this anger stuff has become very real. I'm on call for Copic, and literally, I get one call a day about, what do I do with this angry patient? So, it's really an issue, and the anger is a hurdle. When someone comes in angry, it's hard to be empathic. I'm mostly just thinking about, where do I hide? What do I call 911? So there's a lot of issues around this now. So anger is a big issue. Time is a big issue. And then finally, I think we're all burned out. We're fried. This stuff has been going on forever, and I think we've really run out of empathy. We've only got so much empathy in our buckets, and compassion fatigue is very real. And I like the compassion fatigue's. I like it a little more than even the burnout. The burnout's certainly part of it too. So there's a lot of so this is the sort of the first part of the talk. What is it? It's walking in someone's shoes. What are the hurdles? We just covered those. Is it innate or is it natural? It's a little bit of both, right? But it can be learned and it can be taught, and that's going to be actually the second part of the talk. So my daughter's a social worker, so she loves to launch into didactics on this, and she'll talk about the didactics of cognitive, affective, and behavioral in empathy. And so when she talked about that, and then when I did all my research to figure out what I'm going to say about empathy, my eyes just glassed over. So immediately when I'm going cognitive, affective, and behavioral, I was going, okay, whatever. So I've broken it down a little bit. So there is really the affective, which is seeing and hearing it. There's the feeling it, which is the cognitive part, and then the behavioral is sort of sending the message out. So I've simplified this a little bit. I think I've oversimplified it. So, understand that. But my hope is that, you're not going to remember cognitive, affective, behavioral 3 months from now. But you will remember that in empathy, you got to see what's going on. You got to feel it. You got to send the message back out. So that's something that I think you can actually more easily remember. So it's receiving, it's the internalizing it, and then sending it out. So this is the things we're going to talk about. We're going to jump into these three domains, and then we're going to even, we'll talk about how you might practice this and how it might work. So this is the world of micro expressions and seeing it, the world of nonverbal communication. And there's a lot of stuff. There's a fellow by the name of Paul Ekman who has a wonderful course on this that you can take online. And it's about, I don't know what it is, but he shows you cartoon characters with happiness. And this is the world of micro expressions. When you talk to someone, so when you're talking to a patient, so I'm talking to Mary, and it's a new patient, and she has rheumatoid arthritis. And I say, Mary, tell me about your family. I said, tell me about your mom. And Mary just says, Mom just passed a few months ago. And then there's a brief moment where Mary has a blink moment and a micro expression of sadness. So one of the reasons you got to be looking at someone when you're getting that history. So these world of micro expressions occur very quickly, and you got to be looking at them. And you don't need a PhD to figure this stuff out. You can take Paul Ekman's course. It's METT, I think, is the name of the course online, the micro expression training. But I will tell you that you don't need the course. You'll actually all know this. So we're going to start right here. So we have three very famous people who were all caught doing something around the sex, let's just say. And so we have two people on the ends. One of them is Tiger Woods, a very famous golfer, and then the other is the governor. Both of them were caught basically cheating, and both of them have a micro expression. So these were taken from both of their news conferences. I'll propose to you that the emotions that Tiger has and that the governor have are really the same. What would that emotion be? This is micro expression. They have this look, and then anybody want to shout out what they think the emotion is for Tiger and Arnold?
Anger.
Anger. Okay. Anyone else? Do they really look angry to you? What do you think?
Frustrated.
There probably is some anger. Yeah, anger is more in the middle, but uh, uh, remorse, yes. So it's actually, I think, shame, and of course, I've got, but there's something going on. But there's the look of the downturned eyes, the downturned mouth, pull back. I'm embarrassed a little bit, so there's shame. I think remorse is a good word. Now, Anthony Weiner in the middle did something worse than the two guys on the side, and we don't have to get into the specifics. And anger would be a good description for this. Anybody else have another description for his micro expression? So he was in a press conference and he's talking about what had happened to him, and he got caught doing something rasty. And what's his emotion?
Frustration.
Frustration? Anger? Retaliation, fierce. His eyes are open. He's looking at you, and he has a set in his mouth, right? He's sort of angry. So, yeah. So it's interesting. So these are micro expressions people have. Here's I work at Denver Health, which for the underserved. I take care of this farmer who comes in. He's got rheumatoid arthritis. Things aren't going very well. What's his emotion? You can tell from this wonderful painting. This is obviously sadness, right? So, of course, and this is not one of my patients. This is Van Gogh before he, got into his ear cutting phase. But yeah, and you can see this is a beautiful picture of sadness. So there's some things there. So it doesn't matter which side of whether you have a blue hat or a red hat. So don't really need to know. It doesn't really matter. Both of these guys are skilled communicators in their own ways and with their own types, right? This is the only time that I know of that they actually got together. So which of these guys is happy to be in the room with the other?
No, neither.
You got it, right? So very skilled people with micro expressions, right? And Mr. Obama is not happy to be with Mr. Trump. And Mr. Trump has a set in his mouth. He's not happy to be with Obama, but he's going to give him a good handshake. Sure about that, right? So, there's this micro expression stuff. So these very quick blink things that people do that you have to read. So if you don't read that someone is sad, they're angry, they're frustrated, then you're not going to be able to be empathic about it because you haven't picked it up. And again, people will show you. Actions speak louder than words, right? We have all these wonderful little aphorisms that go on, and basically there is this deal where people will telegraph what they're really feeling. So, and I think you need to pick that up. That's the first part. First part is seeing. It's the affective part, right? So, now the next part of this is the internal part. So this is, you see an emotion, you bring it inside of yourself. Now, if you're in a clinic, you're having a bad clinic day, you're seeing 24, you're overbooked, and everybody comes in and everybody has lost their mother in the last 6 months and they're crying. So are you going to go down the rabbit hole with everyone? Are you going to feel their great sadness? Do you have the chops to do that? Does anybody out there want to say they do or they don't?
I don't.
I don't either. So thank you for jumping out at that. So the secret of the care of the patient is caring for the patient. Words that were written by Dr. Peabody about almost 100 years ago now. And this is a very interesting issue. So William Osler wrote a book about this. So William Osler, it's Osler, I guess, was at Hopkins, I think, at this picture. He wrote a book called Equanimitas, and he talked literally about this. So this was almost 100 years ago, right? It was in oh yeah, I mean actually it was more than 100. And Dr. Osler said that you have to neutralize to see into the inner life of his patients. So this is actually, so the whole word empathy actually comes from the German word Einpath. It's seeing the path into someone. And it actually was not, it didn't become a word in English until around this time, until the turn of the 19th into the 20th century. Interestingly, it came from Germany, perhaps with the great German psychiatrists that, the Freuds and the Adlers, they were talking about this, but they recognized this. So whoever said that, and honestly said, no, I can't go down a rabbit hole 24 times in a day with sad patients. No, you can't. And Freud recognized this, and Osler recognized it. He said you have to neutralize it, you have to feel it, or recognize it, but you can't quite internalize it all the time. So SDIM a couple of years ago wrote an article about this that I think is the best article, and it says you need to acknowledge it, but not really experience it. And they call this emotional attunement. So and I'm not saying that you need to fake it, but what I'm saying is it's complex, and but you do need to acknowledge it and say that really must be hard. You need to really reflect on it without actually going down the rabbit hole with each person that's sad. Now you can go down. Somebody might be sad, and you might join in with them and go down, but it can be tough and difficult and hard. So the final part. The final part is sending the message, and this is probably the most important part. So, and the issue with this is that if you see someone who's sad, you can feel their sadness, you can pick it up and feel it, but if you don't send that message out, they don't know that you're sad, that you acknowledge it. And I think this is what, for me, was the aha moment. So I, cared about my patients. I gave them lots of TLC, and then some of them liked me and some of them didn't, and say, well, what's going on? I wasn't sending the message to them. So, and I think that's going to be the final part and probably the most important part of this talk. So you need to see it, because if you don't see the emotion, you're gonna do it. If you got to feel it, at least acknowledge it, and then you got to send out the message. So the first lesson in sending out the message is this one. This is a very famous painting, and in fact, it's entitled "The Doctor." Go figure, right? And It's was painted in 1890. So there's a child with a febrile illness, and the fellow who commissioned the painting, Tate, said to the painter, "Come up with a painting of social significance." And the painter had lost a child to a febrile illness, and so he recreated, I believe, what had happened. So this is a family physician in these days, right, with a obviously ill child, and hopefully you can see mom and dad in the background. Mom's grieving, dad looking staunchly on, very typically British, right? This is something that doesn't really turn out well. So this famous painting was used, actually, very interestingly, by the AMA. Lyndon Johnson was coming out and was trying to introduce Medicare, and the AMA was staunchly against it at the time, and they used this painting in the doctor's offices of, fight against Medicare. So they come a long way from that time. But do we know this doctor cares? I guess that's the first question. Do you think this doctor cares?
Yeah.
Yeah, you do. And why? Well, it's not the words he's saying, because, of course, it's a painting, right? It's by his nonverbal, by his leaning in, by his looking, by his, and obviously in this day and age, probably there wasn't much he could do that really would help, but you do know that he cares. So this is the first lesson in sending this message out is it's nonverbal, right? So you got to be doing it. So how do you show nonverbal? You got to be sitting down. You got to be this guy's doing it. This is a great doctor's pose. If you have someone that has a high emotion in your office, you need to be sending that message out. So it's good nonverbal, and then it's the second part of it that really lets people know you're empathic is something called reflective listening, and we'll spend the rest of the time on this. So reflective listening is saying back what you've heard. So there's active listening. So active listening is, how do you think the Iowa football team's going to do this year? Joe says back, oh, they're going to do great if they just get a quarterback. Oh, the quarterback. So it's what I did in high school. It's going back and forth talking about sports or anything else, literature or politics. It's going back and forth. That's active, and active wordplay is good. So, and if you're actively listening and having a discussion with someone, that's great. That means you're engaged. Reflective listening is actually a little bit different. So reflective listening means you shut up, you listen to what the person says, and then you say it back. So I'm going to give you an example of reflective listening. So an active listening thing would be, the patient would say, I have rheumatoid arthritis. And I say, rheumatoid arthritis, tell me about it. I've had it for 10 years. Well, tell me more about it. So that's active. I'm going back and forth. Reflective listening is the patient saying, I went to the Denver arthritis clinic. I had rheumatoid arthritis. I was on the etanercept, but then that wore off, and the methotrexate causes mouth sores, and I'm really doing terrible these days. And I have really stopped most of my medicine. I'm just taking the prednisone. So, and reflective listening is me saying back. So it sounds like you're saying you've got rheumatoid arthritis. It was good on the etanercept. Now not doing so good. And these days you're just taking prednisone. Do I have that right? So that's the reflection. And again, think back to the very beginning of my talk when we talked about the patient satisfaction scores. My doctor really listened to me. Okay, when I say that kind of statement back with the body language of the painting, the guy in the painting, the doctor, the patient will then say, "You got it, doc. You heard what I said." That's reflective listening. So. And I use the signpost. I say it sounds like my med students are funny because they follow me around and then they say, well, you say it sounds like to every patient. And I say, yes, I do. But, I only see the patient once a day, so they don't know that I say anything. And I say it actually at the end. So you can do it a couple ways. You can sort of do it as you go through the history. But I actually summarize at the end of my HPI, at the end of my present illness, I always summarize it. And I always say it sounds like, but you can always say, so let me see if I heard it right. Let me see if it sounds like, let me summarize. So what happens if you summarize and you get it wrong? Do people get mad at you? So I'm saying you've got rheumatoid arthritis for 3 years and the patient says, no, it's 10 years. Do they get mad at you about that?
No.
No, they don't. No, they want to get it right. And it is a fascinating prospect or issue to try to do it. So there really is this, and it's something to do. So my suggestion to you, and we're going to get some homework here for you guys. My suggestion is today, at the end of every HPI this afternoon, I want you to do a summary statement, a reflective listening statement. Let me see if I got the story right, right? And go from there. So we were going to do an interactive thing. I don't think I can do it with the team's approach. I can barely hear people. So it's not going to work. So we're going to have to do this as sort of homework. But let me summarize what we've talked about. And this is all about being present and present moment attention. And you've really got to be listening, making good eye contact and connecting with people through both body language and this technique that I did. So here's the secret sauce as we talked about it. So you got to watch the patient. You got to look at the patient. You have to pick up the micro expression stuff. So you got to be looking at someone to pick it up. It's not, it doesn't come out of the sky. So you got to look at the patient, you got to let them talk. You got to listen and feel it. And again, we think of this as a 3-part thing. First is picking up their micro expressions. The second part is, emotional detachment, but internalizing it, acknowledging it, and then sort of sending out that message. And the way you do it is with the body language and good reflective listening. So, and it's also important because it helps at home. This is a wonderful TV show, Scrubs, but it actually works both at home and at work. And so those empathic statements really work. So normally this is my exercise, and you guys could even choose to do it. if you wanted to at the end of this. Or you can even try it with your significant other tonight, or one of your kids. And what you do is you just talk. So I sit down for 2 minutes and tell Sally here an important thing that happened in my life, how I got into public speaking, how I got to be a doctor, how I got into college and what that was. Just a 1 or 2 minute story. And Sally needs to listen. Just listen, not interrupting, not interjecting, and then saying back what she heard. And that's actually the core of this course. Again, I can't do it on Teams, but so be it. And you can certainly try it at home, and you can also try it with your patients. Just shut up and listen. So there's a wonderful study. They trained the providers to just listen and to not interrupt the opening statement. And 5,000 opening statements, and they taped with permission. And 8 people went more than 1 minute. So, right, 0.1% of people talk for more than a minute. So when you talk to patients, this is that whole interrupting 18 seconds to talk thing that you guys have heard about. It's fascinating stuff. When you really look at the literature and the data, people do not. They are very interesting. They do not go on forever. I mean, occasionally there's someone. There's someone who's a little got an illness or something that goes on and on and on. But it's actually very, very, very rare. And it's really interesting to let people talk and tell me a little bit about yourself before we start, and get that kind of thing. So I want you to think about one thing you're going to do different. I'm going to give you the homework. I'm going to tell you what it is. Today, during your afternoon session, I want you with each patient after the HPI, whether it's a bronchitis or vaginal bleeding or got headaches, I want you to do just do the whole history and then say, okay, let me see if I got the story right. I want you to try that with each patient and see how it feels and see how it goes. So, any questions by anybody? So Natalie, Austin, David, Kendra?
I appreciate the presentation. I have an interest in compassion as opposed to empathy. And there's some interesting research, and I come at it from a neurobiology perspective, neurology. There is a difference between empathy and compassion. The only reason I wanted to say something is because there's some interesting research from Germany using functional MRI to show that you can enhance the volume of your prefrontal cortex through certain exercises that emphasize compassion. So it's just really remarkable to me how plastic the whole system is, and that your exercises that you're trying to outline probably could document changes in the empathetic network and the mirror cortex, or the cortex that you were emphasizing. But empathy in my book is more of a reflexive type of thing. As the infant experiences, you whack the hand, you experience what your mother is going through. Whereas compassion is more of a developed system that is a little bit more complicated.
So I got 2 things for you. One of them is Brene Brown's book. It's called Atlas of the Heart, and you have to read it because she actually even makes distinction about how the rabbit hole for empathy might be compassion. So you've got to really dive into what she says. It's a fascinating area and topic, and I agree with you. It is definitely different, and sometimes it can waylay you from doing the empathy. I mean, they're close, but they're not quite the same. And the second thing is, yes, I'll tell you that I just personally, my experience was that I was good at communication, but not great. Some patients didn't like me, and then I really did a lot of training around it. Got much better at it, and I am much more empathic than I used to be. It's very and I hear that from people, and I really feel it. I feel more empathic. I connect. When someone says something, I'm going, that must really be hard. It just sort of comes from doing this. So I do think it's malleable, and I do think you really brought up an interesting point, because we sort of think of the brain as the smartest we're going to be is when you're 20, and then it goes downhill from there. But there is some plasticity to it, I think this stuff is important. But you've got to really you got to read Brene Brown, and it's not a short book, but it's and she gets into some of these issues, the compassion and the empathy. But that's great. That's a great point. Okay, guys, hope all is well, and I hope you're staying cool. And the longest day of the year. It's beautiful out here in Denver, but I appreciate you letting me talk.